The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.
It is a difficult, painful question. Should Canada expand medically assisted dying to those whose illness is their mental health? There are no easy answers, but we'll look for insight tonight. Then, Jayan Jagannathan talks to Dr. Blair Bigham about his book, Death Interrupted, and why modern medicine sometimes leaves the line between dead and alive terribly blurred. It's Wednesday, December 7th, and that's ahead on the agenda. In 2021, almost 10,000 Canadians requested and received medical assistance in dying, or MAiD. That was the year that legislation expanded to mean that people did not have to be terminally ill to apply. In March of 2023, another proposed change will allow those with mental disorders to choose MAiD. With us now on the advisability of that expanded access, we're joined in Vancouver, British Columbia by Dr. Derek Smith, Clinical Professor Emeritus in the Department of Psychiatry at the University of British Columbia. And back here in our studio, Dr. Ramona Coelho, who practices family medicine in London, Ontario, her practice largely comprised of marginalized patients. Dr. Madeline Lee, psychiatrist in the Department of Supportive Care at the University Health Network, and Dr. Sonu Gand, professor in the Faculty of Medicine at the University of Toronto and chief of psychiatry at Humber River Hospital. And we're happy that all of you could join us tonight for what is, to be sure, a controversial and difficult conversation, but one that is necessary given what's about to transpire potentially next March. Let's set this up. In the last few weeks, there have been a spate of urgent statements made by experts, some conservative parliamentarians as well, calling for a delay in the implementation of Bill C-7, which would allow the inclusion of mental illness under the umbrella of MAiD. Ramona Coelho, let's go to you first. What concerns you about allowing severe mental illness from being subject to MAiD?
Thanks for the question. I do think that for other cases of MAiD, like in the case of cancer or severe disabilities, there might be an understanding of prognosis and decline in which to guide a MAiD assessor's ability to judge how this person will do and if this is an appropriate treatment for them as they consider it. But for mental illness, there is currently no evidence to guide those kind of predictions of irredeemability. And I take care of very marginalized patients. I take care of people. In Montreal, I was a home care doctor. I took care of people with mental health addictions in their homes, people with dementia or severe disabilities who were shut in. And so I have seen and worked with many people over many years who have gotten better when I didn't feel like they were going to get better. And that kind of feeling could be transferred in terms of MAiD assessments and lead to deaths of people who might have recovered and had meaningful lives.
So your concern is that they may be in the throes of something awful at the moment, but that is not to suggest that they should throw in the towel.
Not just a moment. Like I would say, yes, I have seen people suffer for several years where I also felt a lot of distress. I'd go home and feel distress. But being on the other side of it, I understand that recovery is possible. And with mental illness, I believe recovery is possible.
Okay. Sonu Gand, I want to ask you about a comment that the federal health minister, Jean-Yves Duclos, said, which is that he insists and the quote is, a strong framework to guide assessors and providers will be in place before MAiD becomes available for those suffering from mental illness. What's still needed for MAiD to be accessible to Canadians suffering from severe mental illness, in your judgment?
So thank you for the question, and thank you for taking on this challenging topic. I know there are a range of views. I should point out at the outset that I'm not a conscientious objector. I have a lot of concerns about where we're headed, but I am the physician chair of my hospital MAiD team. But in terms of this expansion to MAiD for mental illness, I will be blunt. I will say that I believe it's irresponsible. And that's not just based on my opinion, it's based on the evidence of what we will and what we know we will be doing and what we know we will not be doing. So in terms of Minister Duclos' statement, this is the biggest change to psychiatric practice that I have experienced in my career, in my lifetime. I think most psychiatrists would say that. We're now 3 months before this change is supposed to be implemented, where rather than focusing on saying, we're going to help with suicide prevention and help you live better, some patients we're going to say, yes, we understand you want to die. As Dr. Coelho said, patients with mental illness, we can't even honestly tell them that they won't get better. Some of them will, but we will falsely tell them that they won't get better. Based on those assessments, in their moments of despair, they will choose MAiD. And we're on the verge of doing this literally with no standards or guidelines.
So it feels rushed to you?
It's more than rushed. The sunset clause was based on less evidence than required to introduce a sleeping pill in Canada. You can look up what evidence is required to introduce any medication on Health Canada. None of any of that happened for this. The sunset clause was an arbitrary decision, political decision, to say that by March 2023, we will allow MAiD for mental illness. And by the way, along the way, let's figure out how we're going to do it. Minister Duclos is still saying that now, that, oh, don't worry, we'll know how to do it by then. Reassurances are not safeguards. And I'll point out that the expert panel that was tasked with actually providing us safeguards, protocols, and guidelines, they failed to provide any concrete guidelines for how to determine irremediability in mental illness. They specifically say we cannot say the length, types, or number of treatments that should be required before providing death for mental illness. We cannot know how to distinguish between suicidality and MAiD requests for mental illness. And yet, in 3 months from now, we're planning on introducing this.
Okay, let's get another view here. I want to go to Vancouver, British Columbia. Professor Derek Smith, want you to weigh in on this. In as much as in Ottawa, the Parliamentary Committee reviewing the law is going to report back next February. That turns out to be, as we've indicated, just weeks before MAiD automatically expands. I wonder where you stand on the question of whether the legislation ought to be delayed.
Well, I'm opposed to delaying the legislation, and I want to reframe the debate somehow. This is not about expanding MAiD. It is about restoring rights to individuals suffering from psychiatric illness. Now, we know under the Carter rules that a person was eligible for MAiD based just on a psychiatric diagnosis. What happened with C-14 was that the government took this right away, this charter right away from patients with psychiatric illness, using the phrase, your natural death must be reasonably foreseeable. We know as well from the Truchon case in Quebec that this was struck down as unconstitutional. So now we're in the process of restoring a charter right to psychiatric patients, one that was taken away by legislation. How can we proceed with this? Well, first of all, we know that 67% of Canadian psychiatrists believe that in some instances, psychiatric illness can be irremediable. Psychiatric illness can be determined. The request for MAiD can be differentiated from suicidal thoughts. There is huge differences between MAiD and suicide. MAiD is a conscious decision made after a careful assessment, usually involving the family, the primary care physician. Suicide is typically an action taken in private without consultation. We know that the grieving that takes place after MAiD is a positive experience for families and patients. We know from suicide that it's just the opposite. So we don't need to confuse the suicide with MAiD. They're two quite different propositions, and psychiatrists are perfectly capable of sorting that out. We also know from the Benelux countries that there is a small number of patients who will qualify. We're not talking here about huge numbers. My guess is if there's 10 or 15 patients a year in Canada, that might be the maximum number. There's very small numbers, but these people are suffering. They have an interminable illness, and they really need to have their charter right for accessing MAiD restored.
Well, I have a psychiatrist sitting right beside me here who's going to weigh in on this. Dr. Lee, where are you?
So I think I sit somewhere in the middle between Sonu and Derek, actually, which is a challenging place to be. I think that my concerns are, I will come down on the side of saying that I think we need a delay, that I think it's problematic for many reasons, that we're not ready, partly because we're only going to hear what the legislation is finally going to look like like a month before we're actually supposed to provide this, and there aren't. We're also working on, we're supposed to be working on practice guidelines that won't come out until just a couple of months before it's actually going to happen. Even if those things are in place, we know what the legislation is going to look like. If there's any changes, the guidelines, the practice guidelines are out. We won't, and I'm working on an educational curriculum to train people on how to do this safely. None of that will have had the time to be implemented, to actually get out into clinical practice. And I think there are a lot of doctors out there right now still who don't, and public, who don't even know that we're expanding this. And those who do know aren't trained in it. And it's going to take time to expand this. My concern is not specific to mental illness. I agree with Derek's point that we cannot exceptionalize mental illness. We are probably restoring the legislation to what was in the original Supreme Court decision. I'm not trying to exceptionalize mental illness. I actually think the concerns of mental illness apply to all Track 2 cases. So I think we should treat it the same as Track 2. And my concern actually is with the readiness of the healthcare system. That, when Bill C-14 first came out, none of us were prepared. It just came out, and then suddenly we were supposed to be able to provide this. And the end result was, I think there were cases of people who received MAiD who maybe didn't need to, but we never heard about them because they all had terminal illness and they didn't come to light. Then Bill C-7 passed, and there were actually more cases, and those we've been hearing about all over the news. And again, Bill C-7 passed without any preparation, without any time to prepare the system. And I would like to say that we shouldn't do it a third time, because I do think that there will be more. I've got case examples where I think we're going to see more than we saw in the Benelux countries, because our mental health system isn't as well established as it is in the Benelux countries.
This is Belgium, Netherlands, Luxembourg, for those who don't know that acronym. We've got another very thoughtful voice standing by online from Vancouver, British Columbia, and that's Andre Picard, who's in my judgment, the finest health reporter and columnist in the country today. And Andre, we're glad to have you aboard for this discussion as well. And during the course of our conversation here, we're going to ask a lot of questions. And I think, Andre, you put something in one of your columns recently that really gets to the nub of this, and that is whether we're asking the right question. In your column, you wrote, the question is not so much, has there been time to get it right, but rather, can we ever get it right? Which points to, of course, how fraught this subject is. What do you think the answer to that question is that you've posed?
Well, I think, no, we'll never satisfy everyone. There's a fundamental problem with trying to legislate medical practice. When we do that, we always get ourselves in trouble. So, I've been an advocate of governments really have to get out of the way on this issue more than anything else, leave it to the better judgment of medical practitioners. And I think that's how we've seen MAiD play out. Yes, as you just heard, we weren't prepared for the previous bills, C7, C14, but our practitioners did a good job. We have a good MAiD system. It served people well. And we have to remember, this is being pushed by the public. This is being pushed by the courts. The public wants this. They want access to MAiD for irremediable illness, whether it's mental or physical. And the legislators have to catch up. And I think to a certain extent, medical practitioners have to catch up and make it work because it's what people want and it's what they need. This artificial distinction between mental health and, this notion that, well, cancer, it's okay if you're dying of cancer, MAiD's great. But if you have this mental illness that is just untreatable, you're living in misery, well, you should suffer a little bit longer. I'm not a member of the pro-suffering lobby, I'll put it that way.
The pro-suffering lobby. Okay, that's one way to put it. Let's put a face to this story. John Scully is a name that may ring a bell with some people. He's a former television reporter. He has been advocating for access to MAiD. He was on W5, the CTV program, and he described his circumstances thus. Sheldon, the clip, please.
I wake up sick and loathing the day that's to come. I'm in fear of the day that's to come because during the night I've had horrific nightmares and anxiety dreams that fill me with sweat and dread.
Did any treatment work? You've tried everything.
Everything. There's nothing to try for me, nothing left. I've tried every single so-called cure, in quotes. I've tried, there's nothing I haven't tried that I know of.
John's been in a Toronto psychiatric hospital 7 times. He's tried electroconvulsive therapy 19 times. He now takes dozens of pills just to get through the day. And after 35 long years of treatment, still no improvement.
I'm thinking, that's why I'm choosing MAiD, because I don't want to botch it again. I screwed up twice trying to kill myself.
I've known John Scully for 30 years. I used to work with him at CBC. That really puts a face to the story. Ramona Coelho, what do you want to say to him?
Oh, I'm very sympathetic to his plight, of course. There's a few things I'd like to say. When we're talking about a state giving the right of someone to end someone else's life with mental illness. So this is a population discussion, not a conversation of one. I don't doubt that there are some people with irremediable mental illness. The question is, can we identify them correctly? And really, is structural inequalities playing into that? The other thing that I'd like to say, and that I'm sure Dr. Gained could comment on, or Dr. Lee more than me, because I don't know the stats perfectly, is that in the Benelux countries, in jurisdictions that have legalized assisted suicide and euthanasia, suicide rates have gone up, which I think speaks to the question of the contagion of despair, the risk of the contagion of despair.
You're sure there's a connection between these two things?
No, I'm raising the question that I don't think that we've thought about this enough. Could there be a contagion of despair? What happens when you create access? We know that access to lethal means and other things like guns or pesticides, suicide rates go up. What is going to happen to our society when we legislate that, when we go forward? Have we thought about these things? We need to think about Mr. Scully. I mean, that's very important, but we also have to think about the whole population.
Well, let me put that to Dr. Lee, because here's an example where I guess the experts are responsible for having to create policies that can cover the vast population of the country, but then you see that single example. I don't know about you. I mean, my heart breaks for the guy. Everybody's heart breaks for the guy.
Yeah.
How do we figure that out, where we can create one policy for all, and yet help him?
You know, I think it comes back to a point that Andre has written about, right? That we're trying as a society to decide where we stand on the balance between autonomy and protecting the vulnerable. And I want to use the word autonomy versus protection, not paternalism, right? Because paternalism is not a defensible position. No one wants to be paternalistic. It's really about protection. And I'd say that in this debate, there's actually been too much heat and not enough light, right? That there actually is a way of looking at individual cases where I think that you have to, I feel a lot, again, for what John Scully is saying, and I think that when we're trying to protect vulnerable people, we have to think about vulnerabilities beyond just are they accessing services? That's one of them, but also there are many structural and social vulnerabilities. And I think when I start with an individual patient, my first question is, are they vulnerable? I would never make a decision based on a 1-minute video whether somebody is eligible for MAiD or not. But on the surface, looking at his video, he didn't strike me as vulnerable. But I know a little bit about his case. I'd like to know more about his trauma. I'd like to know about his relationships. I'd like to know more about his personality. I'd like to know...
Does any of that matter when he is clear in his own mind this is what he wants?
It is if there's a source of vulnerability there. And I have a role as a clinician to protect that. And what I would say is that the desire for death is really way more complex than people think. It's a collapse of complexity to bring it down to, are you psychotic and delusional or impulsively suicidal or not, right? That's too simplistic. I think people want to die for a multitude of social, psychological, and unconscious factors, and we need to help them understand that.
Dr. Gann, what do you see this case of John Scully? What do you think?
So I see the case, my heart goes out for him. And I think for any empathic human, that would be the natural reaction. I also think that we have to base our policies not on individual cases, but on how they will affect everyone as a population. And I would reframe, actually, Mr. Picard's question. Rather than asking, can we ever get it right? I think the real question is, which mistakes do we want to make? And that reframes it in a different way, because what we know is that when we expand assisted dying beyond end-of-life situations, people shift what they are seeking death for. As Dr. Lee was mentioning, people seek death for different reasons. When MAiD is provided and the end of life is foreseeable, people seek it to avoid suffering from a painful death. When we extend it further and further from death, people seek it to avoid a painful life. They seek it as escape from a painful life, and that's what the data in the Benelux countries shows.
Does that matter, though?
Yes, it does, because what we're doing is we're shifting who is actually seeking it for social reasons that we could fix in other ways. I will use a burning building analogy. A greatly esteemed colleague, Dr. Harvey Chochinov, he's used the analogy of it not being true autonomy. If you have a burning building and somebody decides to jump from that, that's not true autonomy about them wanting to end their lives. We are setting up for the marginalized people in our society, who are the ones who actually preferentially get MAiD in Benelux countries when it's expanded to psychiatric euthanasia, 2-to-1 women to men as well, by the way, increased rates of poverty and social suffering once you expand it. We're taking this and the burning building, those are our policies. Those are our social policies that have led people to these marginalized situations and sometimes even set fire to the building. Our governments, those are the landlords. And what I would suggest to you is that rather than saying, put out the fire, stop the burning, design a safer building, or let's lead people to a safer exit, I think that people who are saying on the side, for example, and Mr. Picard, you're saying that it's autonomy to help the person jump here. I think that out the window, I don't agree with that. I don't think that's a truly autonomous choice.
Okay, let's let him respond. Andre Picard, you want to come back in here?
Well, I don't think it's a good choice to say stay in the building and keep burning. That's what we're saying. We're saying keep suffering. We can't give you an out. Why? Well, because you're poor, because we don't take mental health problems as seriously as physical health ones like cancer. I agree that we really have to improve our access to mental health care. I'd love to have no fire in the building, but the answer is not to say no one can have an out, because it makes us uncomfortable. Some people, you heard in that clip very eloquently, just don't get treatment. It just doesn't work. They want it out. We don't say to cancer patients, hey, there might be this slim hope that there's going to be a new drug to treat you, so you better hang in there a little while, just live with a little more pain, and we're not going to give you MAiD. We have different rules and different for people with mental illness, and it's not fair. Ideally, nobody should have MAiD. Nobody should die. Nobody should be living in poverty, but we shouldn't exclude people because they live in unfortunate circumstances. Right now, MAiD is for the privileged. It's not fair. It's unjust, and we have to fix that balance. We have to give some people the out.
Let me get Derek Smith on this, in as much as the question Dr. Gann just asked, which was, which mistakes do we want to make? Does that reframe this in a way that you find acceptable?
I don't want us to make any mistakes, but there is no evidence to date that the vulnerable are being taken advantage of. Just the opposite. If you look at the statistics, the average person accessing MAiD is over 75, has an illness like cancer or a neurological condition. No evidence of the vulnerable being taken advantage of. Just the opposite. The vulnerable are not having adequate access to MAiD. This is not about collective rights. This is all about the individual rights of patients, of citizens. This is a charter right. The decisions were made based on individuals, Kate Carter, John Touchant, many other cases. So we have to restore the individual charter rights to individuals, including psychiatric patients. If they meet all of the criteria, then they should be eligible to have an assisted death, the same as anybody else. And we know, again, from other countries, that this system can be implemented. It can be implemented safely, and it will benefit a very small number of cases. We can't forget the vast majority of cases have nothing to do with mental illness. This is a small number. and we need to just get on and put it into place.
Let me get Dr. Coelho on that, because this is now twice we've heard this argument that this does not extend rights. This is restoring rights that already existed and have been ignored. Your view on that?
Yeah, so I disagree with Dr. Smith. The Carter case was meant to allow people who would not be able to commit suicide later to have someone help end their life earlier, because we understood that they were in an irreversible state of decline. We do not have that evidence with mental illness. We don't know how to predict that irreversible state of decline. The other thing that is very different from the Benelux countries, so first of all, Dr. Gaines did point out that the Benelux countries do have evidence of psychiatric euthanasia, and it's worrisome. High levels of trauma, double the rate of females to males, people who have like loneliness, relationship breakdowns. These things are worrisome that we're offering death as that for a solution. But what I would say is that also on the ground already for track 2, like you're right, it has just started. So our stats look really good. But I take care of very poor marginalized patients, and some of them have been offered MAiD for their psychosocial suffering. I have a patient who's been waiting a year now. She had a mild spinal cord injury. She can walk, but she's getting pretty desperate. And because
Desperate to do what?
To have MAiD, because she's worried she won't be able to go back to her work. And while she's waiting, she is thinking about MAiD, and she has a 90-day start date. And her father has also been approved for MAiD. He was approved for MAiD within 2 weeks of him saying to his geriatrician, I'm not sure that in the future I want to go to a long-term care home. So he's not even asking to die now. The geriatrician thought it was a great idea to connect him to the MAiD team, which approved him on the basis of his disability, even though he wants MAiD for fear of suffering, of ending up in a long-term care home. So he turned it down, and they said, you can come back when you're ready, and you will be approved for MAiD.
I want, apropos of the geriatric angle on this, I want to ask you about a piece that you wrote for Maclean's magazine, in which you talked about the story of your own mother, who, I guess, is this the way to put it? Who sort of wanted to be put out of her own misery. And let's just read an excerpt from that. You wrote, medical practitioners are trained to evaluate capacity based only on a person's cognitive decision-making ability, but most people also make emotionally based decisions. In cases such as my mother, both rational and irrational thinking may be present at the same time, with cultural factors adding to the complexity, and it may be impossible to distinguish what is driving the desire to die. Is there a right desire to die, and how do we distinguish that from the wrong desire to die, if I can put it that way?
So I don't think I would put it as a right and wrong desire to die.
Okay.
I would come back to saying what I said earlier, that there's a complexity to the desire to die. And one of my concerns is that right now we really don't have good frameworks for evaluating the emotional decision-making and how rational that is. We don't have tools to help us with that yet. And that's why I was getting at the desire to die is far more complex than most people think. I think what we as clinicians need to do is open a space for patients, a curious space where we explore with them what's going on behind that wish. Are there unconscious factors? Are there factors actually that could be addressed? And I think that the problem is not a lot of people know how to have that conversation with patients. And what we aren't even paying attention to is the fact we spend a lot of time talking about autonomy, but actually autonomy is by itself a complex thing. That decisions are not ever purely autonomous, right? Our relationships affect our decisions. Healthcare providers affect patients' decisions, right? Whether my saying to you, it's okay, that's okay for you to die, or it's not okay for you to die, I don't think you should, influences what you think. And we need to train clinicians to have those conversations, and we haven't had the time to do that.
Well, let me try this with Andre Picard. You know, Andre, we've heard on the program already that this is likely not to affect many more than who knows what, 10 or 15 people in the whole country every year. And I don't want to sound flippant in the way I'm asking this question, but is this potentially much ado about not nothing, but not very many people?
I think it's not going to be very many people, but I think it is not much to do about nothing. I think these issues are really, really important to discuss ethics, to make these difficult choices. I get to talk to a lot of MAiD assessors. I know that they really, they struggle with this. These are very difficult decisions to make, but there are many, many difficult decisions in medicine every day. We forget to, how do people die now? We essentially let older people starve to death. That's what we do. MAiD has come and allowed people to alleviate some of that suffering. They used to die with inadequate pain medication from cancer. MAiD has alleviated that. In this case, we're going to allow people with intractable mental illness to get to escape their lives a little earlier rather than, say, jumping off a building or otherwise killing themselves. We can't forget that a lot of these people do end their lives, and they end them in a horrible fashion. I know I'm described by some people on the panel as sort of a pro-MAiD person, and I am. And I think what changed my mind is I covered a story many years ago of a couple, Holocaust survivors, an elderly couple. They felt their lives had come to an end. They were suffering all kinds of minor illnesses, and they held hands and they jumped off the balcony of their luxury apartment. That's an unspeakable, awfully way to die. That's not how people should die. They should have had MAiD. And I know people who with mental illness who have killed themselves, who could have died differently. They didn't have great lives. I think we have to give people this option, and I have a lot of sympathy for the MAiD assessors. These are really, really difficult choices. But ultimately, if you're going to err, it always has to be on the side of patient choice, of patient autonomy, not on what makes us uncomfortable.
Sonu Gam, we're down to our last couple of minutes here, and I want to, this, 62% of Canadians in a recent survey said that they were in favor, either they agree or they are somewhat in agreement with the notion of people being able to have access to MAiD in the event of mental illness. Is that relevant to you?
It's relevant, but I think people need to know what they're getting MAiD for. You had asked the question before about, is there a right or wrong desire to die? I would reframe that again, and I would say we need to be honest about what we are providing death for. And this gets to the fundamental issue right now about mental illness. Notwithstanding Dr. Smith or other expansion activists' beliefs, evidence shows us that we cannot actually predict when a mental illness will not get better in any individual. CAMH says that. It's been studied by the CCA over a year and a half. International studies have looked at that. And so every actual scientific group has agreed, including the Quebec Association favoring expansion. They acknowledge that somebody can get MAiD who could have gotten better and could have regained the will to live. So if we go back to the burning building analogy, the more valid analogy is we don't know how long that fire is going to be burning. Mr. Picard talks about intractable suffering from the mental illness. The reality is we cannot predict that. Those are false predictions. Recent evidence shows that we're probably less than 50-50, which is worse than flipping a coin at doing that.
But does that at the end of the day matter?
It does matter, because if we want
to,
but then we should be honest about it and say our MAiD laws are not based on the false premise of your medical condition will never get better. That is the fundamental safeguard, and that's being bypassed. If society wants to say, well, once you've had enough suffering, then you can get MAiD, that is what the law should say. That should be the honest discourse. It shouldn't be a false premise of providing death under the wrong reasons.
Okay, here's where I've got to jump in because we're plumb out of time, and I appreciate that we barely scratched the surface here at a very complicated ethical discussion, but I'm truly grateful to all of you. Sheldon, thank you for the wide shot. Let's thank all of our guests, Derek Smith, Andre Picard, Ramona Coelho, Madeleine Lee, Sonu Gam, for coming into our studio, both actually and virtually, to have this conversation, which no doubt will continue between now and next March. Thank you, everybody.
Thanks so much.
Thank you.
Thank you.
Dead or alive? For most of human history, the answer to that question was fairly straightforward. Now, it's not so simple, according to Emergency and Intensive Care Unit Dr. Blair Bigham. Doctors, nurses, and paramedics work wonders every day. But does it come with hidden costs, borne not just by medical professionals, but by all of us? He takes up such questions in his new book. It's called Death Interrupted: How Modern Medicine is Complicating the Way We Die. Dr. Blair Bigham joins us now in studio. Welcome.
Thank you.
All right, so this field is not for everybody. And I'm curious, how did you become interested in emergency medicine in the first place?
Yeah, I guess it goes all the way to my childhood when I was in the pool all the time swimming, and that naturally progressed to being a lifeguard. Met a couple paramedics, thought, wow, this stuff's really cool, and then eventually followed in their footsteps and became a paramedic. And after a couple of years doing that, realized that I wanted longer interactions with people, and so I went to medical school, got into emergency medicine and critical care, and I've never looked back.
All right, and we talked about this just before the taping about our favorite shows. Mine is Grey's Anatomy. People who might be watching near-death, resuscitation, and hospital culture from watching TV or movies may not have a real understanding of how maybe different it is or what it really is. Can you tell us sort of the realities of that from TV show to sort of the inside the ICU?
Yeah, I think a lot of the time on TV, and we know from a really neat study where researchers actually watched hundreds of episodes of medical dramas and found that the survival rate from people whose heart stopped was around 90% on television. Oh. But in real life, we know it's closer to 10%. And so we've sort of oversold what resuscitation can accomplish and maybe created some unrealistic expectations in society. Oftentimes, on television, after resuscitation, people just wake up, they're talking, they're moving, they feel well. It's sort of like a very exciting opportunity. But in real life, even a successful resuscitation is not marked with somebody talking to us or being awake. It's marked by maybe a return of a weak pulse, or things that don't necessarily mean that you're going to wake up, walk out of the hospital, and live a good life.
I want to pick up on a point that you had mentioned in terms of you were a paramedic in your early days, both in the air and on the ground, and then you transitioned to being an ICU doctor. How is dealing with an emergency situation different in those two different situations?
As a paramedic, you walk into a scene that has just happened. Someone's just dialed 911. Normally, someone's maybe collapsed just a few minutes ago. You have very little time to collect information. You have very little time to build rapport with family members. And so you're in this mode of rapid action, and you're resuscitating people. Often you're rushing to hospital with lights and sirens, and then you drop the person off in the emergency department, and then you're done. Like, you don't have any idea what happens next. You never see the family again. You might not even know if the patient survived. So it's a very intense but short duration interaction with someone's life where you're trying your best to save it, but you don't know if your actions actually led to the outcome that you wanted. Once you're in the emergency department, instead of having minutes with someone, you might have hours with someone. But even that I found a little unsatisfying, because then again, they get whisked off to the operating room or the intensive care unit or transferred to another hospital, and you're kind of left in the same boat. You don't know what happened to them. You never see them again. In the intensive care unit, instead of minutes or hours, you're usually with people for days, sometimes weeks. You get to know them, you get to know their families, and you really get to see that slow recovery that we just spoke about happen or not happen. And you get a better appreciation, I think, for the limitations of what we can accomplish as physicians. Whereas as a paramedic or an emergency doctor, I often have a lot of hope, but not a lot of long-term insight into what my actions actually did.
All right, I want to do a little bit of a history lesson because you did this in your book, and I'm hoping you can describe how death was sort of determined throughout history, from several decades ago to where we are now.
Yeah, so it used to be really easy because there wasn't anything to do per se when someone got really sick. There weren't antibiotics, there weren't ventilators, there weren't infusion pumps with vasoactive medications. There was really not a lot to do when someone was in the end stages of their life. Often people wouldn't even be taken to a hospital. They would just kind of get sick and die in their own bed. And that allowed their family to be part of the dying process. People would watch their parents die, their grandparents die. And so they became sort of familiar with death, comfortable with death in a way. Once the 60s came around, and then certainly in the 70s, technology advanced to the point where doctors could actually do something for someone who wasn't able to breathe on their own, for example. We could hook them up to machines, we could hook them up to medications, and we could push them through critical illness to the point where sometimes they survived. And so that led to sort of the medicalization of death. People began coming to hospitals. Hospitals developed special units called intensive care units where these very, very sick people would go. And so instead of dying at home, sort of resigned to the fact that there was nothing to be done. People began coming to hospitals, began being intervened upon, and that sort of led to this point now where very few people die at home. Most people will die outside of their home, and many people die in an ICU with sort of maximal intervention occurring. And even now we know that as good as our technology is, as much as we've advanced the science of critical care, at some point everyone's going to die, and often that's on my watch because I have nothing left to offer.
All right, there's a couple of terms that you use interchangeably in your book. You use dead to describe someone who's dead, or even very dead sometimes to describe it. Can we get sort of, what is the medical criteria for death right now?
Sure. So generally we think of someone being dead as when their heart stops beating. And that's certainly what I use to diagnose death all the time. If you don't have a pulse, I diagnose you as dead if I'm not able to restart it after a couple of minutes, maybe half an hour. Sometimes I'll push a resuscitation to 1 hour, you know, someone who was found drowned in a lake and they're hypothermic. But generally, you have maybe 15 to 30 minutes of a resuscitation, and if I don't get your pulse back, you're dead.
Okay.
In my book, I use the term dead because when you're pulseless and we're intervening upon you, we sort of have this lingo amongst us where we use the term dead or very dead to describe someone for whom there's no more hope, there's no more intervention, there's no more effort at resuscitation. And where this comes into play in the ICU is that it gets a little bit more complicated than just, do you have a pulse? Because now we have machines that can generate a pulse. We have machines that can circulate blood when your heart's not beating. We have a lot of technology that means having a pulse isn't necessarily good enough to be declared alive. And where it gets even more complicated is when we talk about brain death. Now that we have a lot of technology, you can actually have a pulse and be dead. We can be generating a pulse. Your heart has a beautiful feature. It's miraculous. It's called automaticity, where it sets its own heart rate. Even if I cut off your head, even if you don't have a head, your heart will beat on its own until it runs out of blood. It's a really interesting feature of the human body. And now that we have technology that can support respirations, which is normally the brain's job to tell you to breathe, it can support heartbeats, it can support blood pressure, we can feed you through an IV or through a tube in your stomach. We can do all these things that don't really require that you have a brain. And so in the ICU, we often have patients who are brain dead who, and the criteria for brain dead is very clear. If your brain ceases to function, you are unable to breathe on your own. And so it's sort of a backwards death in a way. Normally your heart stops and then your brain dies because there's no blood flow. In this case, your brain has died, and so under normal circumstances you wouldn't breathe, and so then your heart would stop.
Right.
But now that I can intervene upon the breathing bit, you can kind of be half alive. Your body is still ticking, but your brain is never going to recover.
Well, let's talk about that. So I want to actually read a quote from your book that looks at this. Let's have that come up. And it reads, "I can take over nearly every aspect of your physiology. Most times I win this battle against death. Organ function recovers, laboratory results improve, patients get better, they wake up, they walk out of the hospital, and they return to their families and friends and jobs and debts and everything else. But then there are times I lose. A slow decomposition, one organ at a time, into oblivion. The problem is this: there comes a point where I know I will lose, but I don't know exactly when. There won't be a return to life, but the line of death hasn't been crossed. It is a no man's land where no person ever wants to be." In that, you sort of describe what I just read. You also say later on that preventing death doesn't equal saving a life, and I'm hoping you can sort of unpack that for us.
Sure. So there's two things in there. The first is that often people, this might sound cruel, but we would use the term unsalvageable sometimes. They're too sick to be saved. Their physiology is too damaged. Their disease is too advanced, and we're supporting them with a ton of life support, and we know that it's not working. Usually we see the doses of our life support medications going up, the ventilator doing more work, not less work, and we sort of realize that we've hit a ceiling of what we can provide. And then we just kind of slowly watch the body deteriorate over a matter of minutes or hours or maybe days, but we know that the writing's on the wall. And so that circumstance happens in the ICU quite frequently. There are other times where we get to a point where you're not going to die, we've prevented death, but we also know that there's so much damage to your body that you're very unlikely to recover very well. Certainly not to your baseline, not to where you were before you came to the ICU. Maybe what that looks like is you're in a nursing home for the rest of your life. Maybe you're able to acknowledge people around you by blinking, maybe by moving your mouth, but you're probably not going to be able to speak. You may not even be able to appreciate your surroundings. And so that's sort of this gray zone we get into where in our resuscitation, where our hope was that you would recover more fully, we've gotten to a point where you are very disabled and maybe not able to appreciate the world around you. And many people would find that circumstance unacceptable. They wouldn't want to live like that. But it's very hard as an ICU doctor because in order to get the good outcome you want, you have to risk that bad outcome or you have to just stop and accept death. So there's a rolling of the dice that happens when we go full court press to try to save someone's life, where we hope that they come out, in a capacity that they would accept, but we know that we may only get halfway. And that can be a really challenging decision point for families, for patients, and for their physicians.
Ultimately, in your book, you are trying to solve what you call the death dilemma, and you come up with an equation. We normally don't do math on this program, but we're going to show a little bit of math. It's mostly words. And you write, technology times resuscitation and glorification plus death denialism equals false hope. False hope drives us to push on in the face of dismal odds. It means that we set aside one of the most important tools in medicine, palliative care, until I would argue the window for effective palliative measures has mostly closed and it is too late to undo extraordinary suffering. Can you unpack that and sort of that equation as well?
Yeah. So let's start at the end of that. And I would say, how would you want to die? And most people would tell me, I would want to die at home in my bed, surrounded by my loved ones, without any pain or anxiety. But that is not what they tell me when they're facing that moment, when they're in the ICU, when they're in the emergency department. They don't say, oh, I'd like to go home and die in peace. They say, I would like you to try everything you can to save my life, even when we all know that we're kind of beyond that. And so that is a lost opportunity for some people to be able to have meaningful interactions with the people they care about in the time they have left. Because instead of palliative care or comfort measures, we push on and medicalize them to the point where perhaps they're on a breathing machine, sedated, they can't interact with people. And so when I say dismal odds, there's often some odds that you might push through, but the odds are really low. And if we roll the dice, then you lose that opportunity. So let's go back to the equation. Let's say that you're going to roll the dice. The reason we can do that is because of technology. If we didn't have technology, I throw up my hands. There's nothing I can do, right? If you ever had a cardiac arrest in the middle of a desert, there's not much I'm going to do to save you. I need my toolkit. I need my nurses. I need my respiratory therapists. I need my pharmacists. Otherwise, you're not going to survive. And so technology is the enabler, and that's why there's a multiplication sign beside it, because you take it out and nothing else matters. But where we get into the situation of false hope or maybe unreasonable hope, those dismal odds, is that two things have happened in society. And the first goes back to what we were talking about with television. We've glorified resuscitation. We've oversold our capabilities. People think that we can save them every time. And so families say, do everything.
Right.
And that's a very difficult position to be in. And then we also have an additional complication, which we haven't spoken about yet, which I've titled death denialism, where in society today, we have a lot of privilege. We have a lot of aspects of our world that reflect ourselves back in our own faces. And so we have this really inflated sense of self-worth and ego, and it's created sort of a world where people think that they have the right to live forever. They don't understand sometimes or appreciate that death comes for us all. And so that's created a situation not only where you think all these tools will work when often they won't, but you also feel that death just, like, why would I die? Why do I have to die? We have all these tools, we have all these technologies, people just think that they can go on forever. And technology has enabled that shift in society from where we used to be very comfortable with death because it happened in our homes, we watched it happen to our loved ones, to a point now where we almost deny that death is coming even when it's very clear that it's happening. So it's created a real conundrum.
Let's talk about palliative care.
Sure.
In what case is palliative care more of an answer than keeping someone hooked up to machines?
Yeah, that's a great question. Palliative care is an advancing field that focuses on people's comfort and joy and their quality of life as opposed to their longevity of life. And so when I say palliative care, a lot of people think, oh, we're giving up, or oh, that means life is going to be shorter. But there's some really interesting research that shows that once we stop medicalizing you, once we focus on your comfort, people can actually live longer than if they're medicalized. Their bodies seem to respond differently to the approach of palliative care. And so people can have a good end with quality time doing the things that matter to them, instead of being proceduralized, poked and prodded, living in an ICU, living in a hospital. It is, at the end of the day, a very personal choice for people to pursue palliative care, but it's one that most people probably aren't offered early enough or might not have a good enough understanding of because it is such a rapidly shifting service that can be provided to people. So palliative care is not necessarily the opposite of critical care. I do a lot of palliative care in the ICU, but it's something that should probably be discussed for patients and their families to consider as they also consider various medical interventions so that they can choose sort of how they roll the dice.
All right, we have a few minutes left and a few more questions to get through, and I want to talk to you about MAiD. Of course,
Sure.
This is something that's obviously being talked about. Among the many experts you spoke to Ashley White, a rural doctor who performs medical assistance in dying. What did she say about people who choose MAiD? Because it's an interesting one and one that sort of opened your eyes a little bit. So it's behind the sort of the socioeconomic factors as well behind that.
Yeah, MAiD is obviously somewhat new to Canada, somewhat new to the medical field, generally speaking, but has proven, at least in Canada, to be somewhat popular. The uptake has been quite high amongst people who have a level of suffering that they just don't want to continue to experience. Ashley works in a rural area and drives hours and hours to meet with people who want MAiD. And her observations are interesting that it's often people who have privilege or education who are aware of MAiD, who are aware of their choices, who request MAiD. And we know now as the MAiD legislation is being, as proposed changes are perhaps coming forward, there's a lot of consideration about people who might not have access to healthcare. And so it's a little bit contentious in that you would hope that people wouldn't be suffering and choose to end their own life through MAiD. But in order for that to be achieved, you have to have social services, you have to have adequate financial resources, you have to have an adequate effort at palliative care. You have to at least have, make sure that you're being treated fully medically before you throw in the towel, because we do know that we can improve people's lives with good old medical therapy before you end up in that situation. So MAiD has brought about another option for the way people die when they're very unwell. But it certainly isn't the silver bullet to the problem that we have these days of the death dilemma.
All right, my last question to you. Is there difficult conversations, ones that you have not only with patients and their family, but with your friends as well? Overall, how are end-of-life conversations changing and how do they need to evolve?
I think the first thing that needs to happen is people need to start having end-of-life conversations. I think I know that the majority of people I meet in the ICU have never had those conversations with
What
their
does that
family
look like?
members. The conversation itself, it means sitting down at the table and talking to your family about, hey, have you ever thought about how you might want to die or what you would want done to you medically if you were in that situation? And many people can be very clear. They can say, I have lived a great life. I would never want to be medicalized. I would never want to be in an ICU or a nursing home. And often you can derive some of those clues from the way they've lived their lives. Some people have an awful lot of dignity, right? So I had a family recently who said, oh, Nana used to go to the hairdresser every week. She would put her makeup on before leaving the house. She was very, very proud. She really cared about her appearance, her integrity, her dignity, and what's happening to her now, she would be horrified. She just wouldn't want that. Whereas other people would say they had a zest for life, they have a grandchild due in 6 months, they would really want to push on and risk that sort of scenario of being incapacitated in a nursing home. So some people can be very, very clear about what they would want. And when families are clear with ICU teams, it does make our job much easier. We can honor that person's wishes without having to guess or argue or have family members sort of opposing each other in their interpretation of what their loved one would want.
All right. Blair, thank you so much. A very important conversation and a really good book. Thank you so much for joining us on the program tonight.
My pleasure. Thank you.
And that is the agenda for Wednesday, December 7th, 2022. Last week, Ontario's Auditor General, Bonnie Lysyk, delivered her final report after a decade in the role. Tomorrow, we'll reflect on this year's accounting and her work over the past 10 years. I'm Steve Paikin. Thanks for watching TVO, for joining us online at tvo.org, and we'll see you again tomorrow.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.